Dear doctors, we are now going to discuss the recent INI-CET questions from INI-CET 2020 exam. Okay. So question number 1 is here. A midwife was examining a pregnant mother in labor. Suddenly she noticed a cord lying outside the introitus. Okay. Cord is lying outside the introitus. What is the next line of management? So what's the diagnosis here? The diagnosis is cord prolapse. The diagnosis is cord prolapse. Okay. The examiner is asking you the first thing that you would do when you see a cord prolapse. Okay. So before going into the answer, I'll tell you what cord prolapse is. We have something called cord prolapse, cord presentation. We also have something called occult prolapse. Okay. We also have something called occult prolapse. What is occult prolapse? What is occult prolapse? Occult prolapse is where cord is placed by the side of the presenting part. Okay, that means if say this is the uterus, this is the cervix and the vagina, and say this is the fetal head. This is the fetal head. If cord is by the side of the presenting part and it has not slipped into the cervix or the vagina yet, we call it occult prolapse. Okay, occult prolapse means cord is by the side of the presenting part. Okay, side of presenting part. Presenting part means head. Okay, presenting part. Okay, so this is the presenting part and this is the cord. Okay, the second condition is cord presentation. What is cord presentation? Okay, cord presentation is where cord is below the presenting part but the membranes are intact. Okay, say this is the uterus, this is say the fetal head. Okay, the cord will be like this. The cord will be like this. Okay, but the unique feature of this is, this condition is the membranes will be intact. The amniotic membrane will be intact. Okay, so when you do a pervaginal examination, you insert your finger into the cervix, you will feel the membrane first. You will feel the membrane first. Okay, and through the membrane you will feel the cord. Through the membrane only you will feel the cord. This is cord presentation. Okay, next condition is cord prolapse. Cord prolapse. Cord prolapse is where membranes rupture and cord slips through the cervix into the vagina or to the vulva. Okay, say this is the presenting part. This is the presenting part. Here there are no membranes. The cord either slips like this or the cord completely comes outside. Okay, this is cord prolapse. Okay, so the main difference is what? In cord presentation, membranes are intact. Membranes are intact. Cord is below the presenting part with intact membranes. With intact membranes. And in cord prolapse, the cord slips into the vagina or the vulva. Vulva, no membranes. Okay, with ruptured membranes. Ruptured membranes. Okay. So this is the basic difference between occult prolapse, cord presentation and cord prolapse. So the given condition is what? Cord prolapse, because the examiner says cord is lying outside the introitus. Okay. So how are we going to manage cord prolapse? The incidence is 1 in 300 deliveries. Okay. The incidence of cord prolapse is 1 in 300 deliveries. Okay. So what are the predisposing factors? Predisposing factors or the causes for cord prolapse. The predisposing factors are malpresentation, number 1. Okay, especially transverse lie. Okay, transverse lie. Transverse lie. The second is breech presentation. Breech. The third is contracted pelvis. Contracted pelvis. Whenever there is over distension, there are chances of cord prolapse, and therefore twin pregnancy, hydramnios, hydramnios, okay, prematurity, that is preterm, okay, prematurity, okay, placenta previa, okay, and PROM especially during procedures like ECV, These are the causes or the predisposing factors for cord prolapse, okay. Transverse live breach, any malpresentation can lead to cord prolapse because the head is the part that snugly fits into the cervix. Now here when the head is not near the cervix and it is breached near the cervix, or there is no fetal pole near the cervix like in transverse live, obviously there is empty space between the presenting part and the cervix through which the cord slips, okay. So transverse live, breach, contracted pelvis, twin, hydramnios, prematurity, placenta previa and PROM during ECV are predisposing factors for cord prolapse, okay. Next is management part. How do we manage cord presentation? How do we manage cord prolapse? Okay, first thing is cord presentation. Please remember, whenever there is cord presentation, okay, please do not reposition the cord. Very, very important MCQ point. Do not reposition the cord. Do not try to push it above the fetal head, okay. See, this is cord presentation. Now, here is the cord. What will happen if you try to push this part up, okay? When you try to push this part up, no, the intact membranes will rupture, okay? So, this will convert a cord presentation to cord prolapse, and it's even more dangerous. Cord prolapse is much more dangerous than cord presentation because once the membranes rupture, the uterus will start vigorously contracting and start compressing the cord, okay? That will lead to fetal hypoxia. So, cord presentation should never be repositioned. Rather, if the baby is term, if the baby is a term baby, you do an immediate cesarean section. Okay, that's cord presentation. This is for cord presentation. Okay, obviously you will do a pervaginal examination only if it is a term pregnancy, right? If only the patient comes in labor, you're going to do a pervaginal examination in term pregnancy, or else why would you do a pervaginal examination? Only by doing a pervaginal examination, you'll come to know that there is cord presentation, okay? So, cord presentation should not be repositioned. Immediate cesarean section is what is supposed to be done, okay? Next is cord prolapse. Before going into the definitive measures of cord prolapse, I'll tell you some important preliminary measures, okay? What are the preliminary measures? Point number 1, the most important point, replace the cord or reposition the cord inside the vagina. Okay? So, when I say replace the cord inside the vagina, it does not mean that you have to put the cord above the presenting part. It only means that push it inside the vagina, not above the head. Okay, if you try to put it above the head, then the cord will definitely be placed between the head and the pelvis and it will lead to compression. Okay, put it inside the vagina. Why put it inside the vagina? Whenever it's outside, if it gets exposed to the atmospheric environment, the cord vessels will constrict. Okay, and that will further aggravate the hypoxia. So, put it inside the vagina. Okay, and do few other measures like stop oxytocin. Okay, because as contraction increases, the fetal hypoxia simultaneously increases. Okay, stop oxytocin and then lift the presenting part. Fill the bladder, lift the presenting part up. Okay, lift the presenting part up. Okay, so that it does not sit on the cord, so that it does not compress the cord. Okay, next is position, exaggerated Sims position. Put the patient on exaggerated Sims position. Okay, stop oxytocin, fill the bladder. Once you fill the bladder, obviously the presenting part would move up. Okay, or push the presenting part up. Exaggerate, put the patient in exaggerated Sims position and replace the cord immediately. Okay, and then coming to the definitive management, that's delivery part. When to deliver and how to deliver, obviously immediate delivery. Okay, so now to decide on the mode of delivery, you first see the lie. First see the what? See the lie. Okay. If it is transverse lie, if it is transverse lie, regardless of whether the baby is alive or dead, what has to be performed is a cesarean section. Okay. Deliver the baby by cesarean section. If it is transverse lie, deliver by cesarean section for both live and dead baby. Okay. For both live and dead baby. In case it is a longitudinal lie, if it's a longitudinal lie, okay, see whether the dilatation is full or the patient is in early labor. Okay. If the patient is in early labor, if the patient is in early labor, okay, the dilatation is not full, the head is not engaged, then you're supposed to do an emergency cesarean section. Okay. Emergency cesarean section. If the dilatation is full dilatation and the head is engaged, if the dilatation is full and the head is engaged, do what? Conduct a forceps delivery. Forceps delivery. Okay. That means instrumental delivery. Instrumental delivery. This is for longitudinal lie, live baby with longitudinal lie. Okay. If it's a longitudinal lie with the dead baby, longitudinal lie with live baby. If it's longitudinal lie with dead baby, okay, whether it's early labor or late labor does not matter. Wait for vaginal delivery. Wait for what? Vaginal delivery. That's it. Okay. I think I've made it simple. If it's transverse lie, whether the baby is alive or dead, just deliver by C-section. If it's longitudinal lie, see whether the baby is alive or dead. Okay. If the baby is alive, for full dilatation, deliver by instruments, and for early labor, you do a cesarean section. If the baby is already dead, then there is no point in doing cesarean section. Wait for spontaneous vaginal delivery. Okay. So this is how you will manage cord prolapse. Now look at the question. Midwife was examining a pregnant mother in labor. Suddenly she noticed a cord lying outside the introitus. Next line of management is definitely not wait and watch. When the cord is already outside, it's a dumb attitude to wait and watch. Okay, so definitely not. Shift to the delivery room. Of course, you have to shift to the delivery room. I accept. But before you shift to the delivery room, you have to safeguard the cord first, right? With the cord outside the introitus, you can't just shift her to the delivery room because moving the patient will bring more and more cord out. Okay, so you have to first replace the cord inside the vagina. Put the cord inside the vagina and only then move the patient. Until then, don't move the patient because it will, push more and more cord out of the vagina. Okay. So next question here is on modified Robson's classification. Next question is on modified Robson classification. Modified Robson classification. What is modified Robson? This classification system helps to compare cesarean rates in between hospitals. Like say whether the cesarean has been performed with valid reason or what was the indication for cesarean. So that is what is modified Robson classification. And according to this, we have 10 different segments in this modified Robson classification. I'll tell you now. Modified Robson classification. Modified Robson classification. Okay. What is class 1 according to this classification? Class 1 is nulliparous, single cephalic, more than or equal to 37 weeks with spontaneous labor. Okay. You do a cesarean section for such a patient, it comes under Robson's classification 1. Robson classification 1. What is it? Nulliparous, single cephalic, more than 37 weeks with spontaneous labor. Okay. What is modified Robson classification 2? Modified Robson classification 2 is again nulliparous, single cephalic, more than 37 weeks, induced labor. induced labor or cesarean section before labor. Okay, induced labor or cesarean section before labor. So classification 2 is nulliparous single cephalic more than 37 weeks with induced labor or cesarean section before labor. Okay, what is Robson's class 3? Robson's class 3 is multiparous. Multiparous. Okay, again single cephalic more than 37 weeks, spontaneous labor. Okay, single cephalic more than 37 weeks, spontaneous labor. Okay, class 4. What is Robson class 4? Class 4 is again multiparous, single cephalic more than 37 weeks, induced labor. Induced labor or cesarean section before labor. Induced labor or cesarean section before labor. Okay, so we have seen 1, 2, 3, 4. Next is class 5. Okay, what is Robson class 5? Robson's class 5 is multiparous, single cephalic more than 37 weeks, previous cesarean section. Okay, multiparous, single cephalic more than 37 weeks, previous cesarean section. So we have finished 5. Nulliparous single cephalic more than 37 weeks, spontaneous labor. Nulliparous single cephalic more than 37 weeks, induced labor or CS before labor. Multiparous single cephalic more than 37 weeks, spontaneous labor. Multiparous single cephalic more than 37 weeks, induced labor or cesarean section before labor. Multiparous single cephalic more than 37 weeks with previous cesarean section. Okay, next is this. Class 6. What is class 6? All nulliparous breech. Okay, cesarean section for nulliparous breech is class 6. Okay, what is class 7? Class 7 is all multiparous breech. Okay, all nulliparous breech is class 6. All multiparous breech is class 7 and this includes previous cesarean section. Includes previous cesarean section. Okay. Next is all multiple pregnancies. Cesarean section for any type of multiple pregnancy. Okay, is class 8. Cesarean section for any type of multiple pregnancy is class 8 and this again includes previous cesarean section. Okay. Next is all abnormal lie. All abnormal lie. Cesarean section for any abnormal lie comes under class 9 and this again includes previous cesarean section. Okay. Next is all single cephalic preterm. Preterm means less than or equal to 36 weeks. Preterm. Okay. Cesarean sections for any preterm is Robson classification class 10 and this again includes previous cesarean section. Okay. So 10 classes are there. Okay. 5 classes does not deal with, the first 4 does not deal with previous cesarean section. From 5th onwards, okay, previous cesarean section can fall anywhere between 5 and 10. Okay. Nulliparous single cephalic more than 37 weeks spontaneous labor is class 1. Nulliparous single cephalic more than 37 weeks induced labor or cesarean section before labor is class 2. Multiparous single cephalic more than 37 weeks spontaneous labor is class 3. Multiparous single cephalic more than 37 weeks induced labor or cesarean before labor is class 4. Multiparous single cephalic more than 37 weeks with previous cesarean is class 5. All nulliparous breech fall under class 6. All multiparous breech including previous cesarean class 7. All multiple pregnancy class 8. All abnormal lie class 9 and all single cephalic preterm deliveries fall under class 10. This is modified Robson classification. So here the question is modified Robson classification group 1 means the simplest. Nulliparous single spontaneous labor. Okay, group 1 is what? Nulliparous single spontaneous labor. Okay, all are true about breech presentation in labor except. Okay, First, we'll discuss a few points about breech presentation, where to do external cephalic version and all that, and then we'll come back to this question. So remember, breech in labor carries a small immediate risk to the baby. Assisted breech delivery carries a small immediate risk to the baby, but long-term risk, if the delivery is successful, there is no increase in long-term risk. Okay, so where all should we avoid assisted breech delivery? What are the contraindications? Contraindications for assisted breech delivery. Okay, assisted breech delivery means vaginal breech delivery. Okay, assisted breech delivery means what? Vaginal breech delivery. What are the contraindications for assisted breech delivery? They are: point number 1, lack of trained birth attendant. Lack of trained birth attendant. That means a trained birth attendant should be there, okay, to conduct assisted breech delivery. Someone who's experienced in doing it. Okay. Point number 2, footling or knee breech. Footling or knee breech is a contraindication for assisted breech delivery. That means which type of breech can be delivered by assisted breech delivery? Yes, extended breech or frank breech is the most favorable one. Flexed breech is also okay, but footling or knee breech should never be delivered by what? Assisted breech delivery. Okay. Next is large baby. Large baby means more than 3.8 kg. Large baby means more than 3.8 kg. Okay. Next is IUGR baby. IUGR baby means less than 2 kg. IUGR baby means less than 2 kg. Okay. Next is hyperextended fetal neck. Hyperextended fetal neck. So, for a successful assisted breech delivery, the fetal head should be well flexed. Okay. Hyperextended fetal neck in labor is a contraindication for assisted breech delivery. Next is previous cesarean section. Okay. Previous cesarean section is a contraindication for assisted breech delivery. Okay. So, apart from this, if there is any other obstetric indication for cesarean section, like say placenta previa, obstetric indication like say placenta previa or abruption or any other reason for cesarean section would be a contraindication. The last contraindication is cephalopelvic disproportion. Okay. Last contraindication is what? Cephalopelvic disproportion. So, altogether there are 8 contraindications for assisted breech delivery. What are they? Lack of trained birth attendant, footling or knee breech, large baby weighing more than 3.8 kg, small baby or IUGR baby weighing less than 2 kg, hyperextended fetal neck in labor, previous cesarean section, placenta previa or any other obstetric indications for cesarean section like placenta previa, and cephalopelvic disproportion. Okay, fine. So, there are certain do's and don'ts in conducting assisted breech delivery. Okay, do's and don'ts in conducting assisted breech delivery. What are they? Okay, assisted breech delivery should be conducted only in places where facilities for LSCS are available. Facilities for cesarean section are available. This is where it should be conducted, because any time the baby might go into fetal distress and any time the mother might require a cesarean section. Okay, so it has to be conducted only in a place or a hospital where deliveries for this is available. Okay. Second is what? Can you induce labor? Can you induce labor in assisted breech delivery? The answer is yes, you can. Okay. Can you augment labor? Can augmentation be done? Usually augmentation should be avoided. Why? Because when you augment, the uterine contractions become more vigorous and the soft part which is below the presenting part is breech here, right? So, breech is comparatively soft and therefore breech gets easily pushed out during a contraction when the cervix is still inadequately dilated and the head gets caught. Okay, so you have to give good amount of time for the cervix to completely dilate, and only then the breech has to come out, or if not, the breech will first deliver and the head will get caught, which will result in strangulation and fetal hypoxia. Okay, so augmentation should not be done. Okay, Does the mother require routine analgesia? Routine analgesia? Again, answer is no. Routine analgesia is not required in assisted breech delivery. Fetal blood sampling, can it be done from the buttock? Fetal blood sampling. Fetal blood sampling is one technique to identify fetal hypoxia, right? Can we do fetal blood sampling here? Again, no. Fetal blood sampling should not be done. Okay. So, continuous monitoring, continuous electronic fetal monitoring is required. Continuous electronic fetal monitoring is required for all assisted breech deliveries because it's one kind of high-risk delivery, right? So, continuous electronic fetal monitoring is required. Careful assessment is required. Apart from that, routine radiological pelvimetry, routine X-ray, radiological pelvimetry to see if there is CPD. Sometimes we do, okay, but this is not done nowadays, okay. So, this is not required, okay. Preterm breech. Do we read a routine cesarean section? Routine cesarean section. Should we perform a cesarean section for all preterm breech? No. Some preterm breech can be delivered by vaginal delivery. In fact, when I told you, I didn't tell you that preterm is a contraindication for assisted breech delivery. See, I told you 8 contraindications for assisted breech delivery, out of which I told you IUGR is a contraindication. Baby weighing less than 2 kg is a contraindication, but preterm is not a contraindication. Okay, preterm is not a contraindication. Next is episiotomy. Episiotomy. Should we perform a routine episiotomy? Whenever you see this word routine, you can boldly say no. Okay. So, routine X-ray, no. Routine cesarean for preterm, no. Routine episiotomy, no. Okay. Breech extraction, again routine breech extraction, no. Okay. You need not perform a routine breech extraction. Okay. Routine breech extraction. Okay. No, that again is not required. Fine. Maneuvers you can do for after coming head. If you want, you can do maneuvers. If you want, you can put forceps. So, forceps and all are allowed. Okay. Forceps is allowed. Maneuvers are allowed. Okay. So, these are the do's and don'ts in assisted breech delivery. Now, let's get back to the question here. All are true about breech presentation in labor, except, I think that word except is missing. Continuous electronic fetal monitoring is required for breech during labor. This is absolutely correct. Correct. I told you. It's a high risk delivery. Okay. It's a high risk. Breech is high risk. Okay. So, definitely continuous electronic fetal monitoring is required. Vaginal breech delivery is allowed in hospitals where facilities for emergency cesarean section is available. That's again correct. Okay. It has to be performed only in places where facilities for emergency cesarean section are available. Breech diagnosed for the first time in labor is a contraindication for vaginal delivery. No. This is a wrong statement. Okay. Breech diagnosed during labor for the first time during labor is not a contraindication. You can still proceed for assisted breech delivery. In the list of contraindications for ABD, we don't have this point at all. Okay. Vaginal breech delivery should be attempted in settings where a trained person is present. That's again correct. Okay. So, all are true about breech presentation in labor except. So, this is the false statement. All others are true statements. Okay. Next is about HPV vaccine. Development of recombinant HPV vaccine is based on which viral protein? Okay. See, we have various viral proteins. We have the E6 and E7 oncoproteins, viral proteins, E1 and E2 proteins. Of course, all these are viral. All the proteins that are mentioned here are HPV viral proteins. HPV viral proteins. Okay. Out of which the one that is related to the vaccine is L1. Okay, L1, very important MCQ point. L1, okay, it is based on which viral protein? It is based on L1. L1 is the protein which we use in vaccination. Okay, subunit. Few more points on HPV vaccine, HPV virus, I'll tell you. How many subtypes have we identified till now? We have identified 150 subtypes till now. Okay, we have totally identified 150 subtypes till now, out of which 40 infect the lower genital tract. Okay, how many infect the lower genital tract? 40 infect the lower genital tract, out of which 15 are oncogenic strains. 15 are oncogenic strains. 150 subtypes have been identified, out of which 40 infect the lower genital tract, out of which 15 are oncogenic. Okay. So in which age group there is highest prevalence? Highest prevalence is in between 20 and 30. Okay. Highest prevalence is between 20 and 30 years, and in fact, genital HPV is the most common sexually transmitted disease worldwide. So when I ask which is the most common sexually transmitted disease worldwide, students usually tell the answer as either chlamydia or tuberculosis or sometimes gonorrhea, but all these three are wrong answers. The correct answer is human papilloma virus. Human papilloma virus is the most common genital infection worldwide. Okay, so we have two important strains here. One is HPV 16, the other one is HPV 18. Okay, HPV 16 is the most common. HPV 16 is related to squamous cell cancer. Okay. HPV 18 is the second most common. HPV 18 is more often causes adenocarcinoma of the cervix. And also remember, HPV 18 is the most virulent. So I hope you understand the difference between most common and most virulent. Okay. Most common means it is frequently seen, but it is not that oncogenic as HPV 18. Most of the time HPV 16 gets cleared by the infection gets cleared by itself. But HPV 18 once infects a lady, it does not disappear or does not clear by itself. Rather, most of the time it develops malignancy. Okay, so HPV 18 is the most virulent and HPV 16 is the most common. Okay. So we have three types of vaccines, right? So the first one is HPV 2. What is it called as? It is called as Cervarix. HPV 4 is called as Gardasil 4. And HPV 9 is called as Gardasil 9. Okay. So what are the strains included? HPV 2 includes 16 and 18. The two most important oncogenic strains. HPV 4 includes 6, 11, 16 and 18. HPV 9 includes 6, 11, 16, 18, 31, 33, 45, 52 and 58. Okay. This question, the strains included in Gardasil 9 was asked in AIIMS 2019. AIIMS 2019 question. Okay. Gardasil 9 or HPV 9. What are the strains included? 6, 11, 16, 18, 31, 33, 45, 52, 58. 6, 11, 16, 18, 31, 33, 45, 52 and 58. Okay. What is the ideal age for vaccination? The ideal age for vaccination is 11 to 12 years. The vaccine can be given as early as 9 years. It can be given as late as 45 years. But then ideal, when you see this word ideal, the answer is 11 to 12 years. Okay. Coming to the number of doses for girls less than 15 years of age. For girls less than 15 years of age, the number of doses are 2. And for girls older than 15 years of age, the number of doses are 3. Okay, 2 doses for girls less than 15 years and 3 doses for more than 15 years. Okay, and remember the efficacy of the vaccine is 100%. Efficacy of the vaccine is 100%. Very catchy number, very important, very attractive number, important MCQ. Okay, 100%. And what is the duration of protection? The duration of protection is 6.4 years. The duration of protection is what? 6.4 years. Okay. So very important MCQ. And can you give the vaccine for sexually active women? Supposing say she's a Paris lady. She wants to get vaccine. Ideally the vaccine has to be given for virgin girls, right? Because it basically prevents infection that is sexually transmitted. So once the lady is already sexually active, can you give the vaccine? Answer is yes, you can. Even for sexually active women, we can give the vaccine. The guideline recommends giving the vaccine even for Paris women. Okay. But during pregnancy, you should not give. During pregnancy, The vaccine should not be given during pregnancy. It's not a live vaccine, it's a killed vaccine, but still this vaccine should be avoided because we do not know the safety profile of this vaccine during pregnancy. We do not know the safety profile of the adjuvants used in this vaccine during pregnancy. Okay. Lactation, yes. You can give for lactating mother. You can also give this vaccine for immunocompromised women. Okay. So sexually active women, lactating mothers, immunocompromised women can get the vaccine, but pregnant women should not take the vaccine. Okay. And even after vaccination, routine guideline should be followed. The routine screening guideline should be followed even after vaccination. That means 3-yearly PAP or 5-yearly co-testing, whatever you do for your patients, you have to follow the same protocol for vaccinated women too. Okay, what all does it prevent? This vaccine prevents not only cervical cancer, but also vaginal cancer, vulval cancer, anal cancer, penile cancer, wherever the HPV can infect. Okay, penile cancer and malignancies involving the oropharynx and the larynx. Okay, this vaccine can protect against cervical cancer, vaginal cancer, vulval cancer, anal cancer, penile cancer and oropharynx, and this vaccine can also be given for males. It is approved for use in males too. Okay, so these are the points about vaccine. So basically the question started with what? The recombinant, the viral protein that is used in recombinant HPV vaccine, and the viral protein that is used is L1. Okay, so this is about HPV vaccine. Okay, how many oncogenic subtypes are there? 15. Okay, which is the most common? HPV 16. Most virulent? HPV 18. Second most common? HPV 18. Okay, what are the strains included in Gardasil 9? 6, 11, 16, 18, 31, 33, 45, 52 and 58. Okay, so can sexually active women take the vaccine? Yes. Lactating mothers? Yes. Pregnant women? No. Okay, so males? Yes, even males can take the vaccine. Okay, next question to you all. A female attends gynec OPD with history of frequent Trichomonas vaginalis infection. Trichomonas vaginalis infection. She was advised for Pap smear. What's the role of Pap smear in this patient? Role of Pap smear in this patient. Okay. See, Pap smear is not only used to diagnose or to screen against cancer cervix. Pap smear can also diagnose certain other infections apart from cancer cervix. It can also diagnose certain infections. Okay. So what all can it diagnose? Non-neoplastic findings in Pap. Okay. The question is on non-neoplastic findings in Pap. Okay. Pap can diagnose infections with Trichomonas. Pap can diagnose infections with Trichomonas. Pap can diagnose infections with Candida, infections with bacterial vaginosis, that is infection with Gardnerella vaginalis. It can diagnose infection with actinomyces, okay, Trichomonas, Candida, bacterial vaginosis, actinomyces. Apart from these, it can diagnose cellular variations, okay, like atrophy, say postmenopausal patient, there is no adequate sample, the cervical smear is scanty. Yes, Pap smear can diagnose. Okay, atrophy, then keratosis, then metaplasia. It can diagnose metaplasia. Atrophy, keratosis and metaplasia. Okay. Apart from this, it can also diagnose certain inflammatory changes. Okay. Inflammatory changes and cellular changes consistent with herpes, radiation exposure, intrauterine devices. Okay, intrauterine devices, herpes, radiation exposure, all these can be diagnosed. And last but not the least, Pap smear can also have endometrial cells in women more than 45 years old. Okay, endometrial cells in women more than 45 years old. Okay, so all these can be diagnosed using a Pap smear. Okay, so it can diagnose infections with Trichomonas candida, it can diagnose bacterial vaginosis, it can also see cellular changes consistent with herpes, radiation, intrauterine device, actinomyces, atrophy, keratosis, metaplasia, inflammatory changes, and finally endometrial cells in women beyond 45. Okay, so the question is here, a female attends gynecopedy with history of frequent Trichomonas vaginalis infection. She was advised for Pap smear. So why would you advise Pap smear for a lady with the frequent Trichomonas infection? Because Pap smear itself is one diagnostic technique for Trichomonas. Pap smear can diagnose Trichomonas infection. That's the key point here. Okay, it helps to screen for cervical cancer. That's a correct statement, but not relevant to this question. Helps to diagnose cancer in the genital tract. That's true. Helps to demonstrate Trichomonas vaginalis infection is the single best answer. Okay, this is the single best answer. Helps to diagnose other associated genital infection is also correct. Bacterial vaginosis can be diagnosed, candida can be diagnosed, but Trichomonas can be diagnosed with Pap smear, and that is what is relevant to this patient's history. Okay, so this is the perfect answer here. Next, we have a question on Pathogram. Pathogram should be started at a cervical dilatation of, simple and a very easy question. Pathogram should be started at a cervical dilatation of 4 centimeter. Okay, pathogram should be started at a cervical dilatation of 4 centimeter. Okay, now I'll tell you a few more points about pathogram. Okay, now see, this is an old WHO pathogram where we have latent phase and active phase. Okay, so this column is for latent phase and this is for active phase. But in the new WHO pathogram, we do not have the latent phase. We only have the active phase. So this part has been cut. This part has been cut, and this line, alert line and the action line, whatever you see here, okay, this alert line and the action line are moved to the y-axis, okay. So this is where it is. This is the alert line and this is the action line, okay, alert and the action line, okay. Now remember, pathogram, the alert line begins at 4 centimeter and that is when you have to start plotting the pathogram, okay. Now few important MCQs, I'm not going to discuss the entire pathogram here because it's INI-CET question paper. A few important MCQ points I'll tell you on this pathogram, okay. Now each small box in a pathogram corresponds to how many hours? Each small box in a pathogram corresponds to half an hour. Okay, each small box in a pathogram corresponds to half an hour. Okay, what is dilatation marked with? Dilatation is marked with the alphabet X. Dilatation is marked with the alphabet X. Okay, what is descent of the fetal head? Dilatation means it's cervical dilatation. Okay, what is descent of the fetal head marked with? Okay, descent of the head is marked with alphabet O. Descent of the fetal head is marked with alphabet O. Okay. What is the time gap between alert and action line? The time gap between these two lines, alert and the action line, is 4 hours. The time gap between alert and action line is 4 hours. Okay. What do you mean by adequate contractions? Adequate contraction means at least 3 contraction has to be there. At least 3 contraction has to be there in a 10-minute period. In a 10-minute period, each lasting for more than 40 seconds. Okay, at least 3 contraction has to be there in a 10-minute period, each lasting for more than 40 seconds. Okay, this is adequate contraction. Okay, next question here. How do you assess the descent of the fetal head? What is the name of the technique with which we assess the descent of the fetal head? The technique with which we assess the descent of the fetal head is Crichton method. Okay, the technique with which we assess the descent of the fetal head is Crichton method. Okay, fine. Next important question on pathogram. If in the contraction column, okay, see, this is the contraction column. This is where we usually mark the contractions. Okay, you can see there are 1, 2, 3, 4, 5 boxes in each column. Okay, now either they will be marked with dots, or they will be marked with stripes, or they will be completely shaded. They'll be completely shaded like this. Okay, now what does each of them mean? What do they mean? Okay, if the box is marked with dots, it means that the duration of contraction was less than 20 seconds. Less than 20 seconds. Okay, if there are stripes inside the box, okay, if there are stripes, then it means the contraction, the duration of the contraction is 20 to somewhere between 20 and 40 seconds. Okay, 20 to 40 seconds. And if it's fully shaded like this, it means the contraction lasted for more than 40 seconds. Okay, so this basically is to denote the duration of contraction, whether it lasted for less than 20 seconds or 20 to 40 seconds or more than 40 seconds. So dots means less than 20 seconds, stripes 20 to 40 seconds, and full shading means more than 40 seconds. Okay, so we have 3 types of dilatation abnormalities. Basically, pathogram is to see whether the dilatation is proceeding at a good rate, right? So there are 3 types of dilatation abnormalities. One is prolonged latent phase. The second is primary dysfunctional labor. The third is secondary arrest of cervical dilatation. Okay. Latent phase, prolonged. What is prolonged latent phase? If the latent phase exceeds 8 hours in a nully or 6 hours in a multi, we call it prolonged latent phase. It should not exceed 8 hours in a nully and 6 hours in a multi. That's prolonged latent phase. Okay. What is primary dysfunctional labor? If the dilatation is slow from the very beginning, okay. See, this is basically where we plot the dilatation. Like this we plot the dilatation, no? Like this we plot the dilatation. Okay. If all the alphabet X is the alphabet that we use for dilatation abnormalities. If all the alphabet X fall to the right of the alert line, okay. If all the alphabet X fall to the right of the alert line and no alphabet X is to the left of the alert line, it is primary dysfunctional labor. That means, say if here you start plotting the pathogram, if the next X is here, the next X is here, where is the graph? The graph is to the, this is left side, this is right side, okay. The graph is to the left of the alert line, so this graph is a normal graph. This is a normal graph, okay. If the graph exactly falls on the alert line, it's like this, like this, like this, and like this. If it is like this, green color, green is also normal. When will I call it abnormal? I'll call it abnormal if any of the alphabet X is to the right of the alert line. That means if the graph goes like this, to the right of the alert line, in between the alert and the action line, or to the right of the action line, then it's abnormal. Okay, so when will I call it primary dysfunctional labor? Primary dysfunctional labor. Primary dysfunctional labor is when the alphabet X is to the, none of the alphabet X are to the left of the alert line. From the very beginning, the dilatation is slow and all the alphabet X is to the right of the alert line. All the alphabet X is to the right of the alert line. That's primary dysfunctional labor. Okay. On the other hand, we have one more called secondary arrest of cervical dilatation. Secondary arrest of cervical dilatation. What is secondary arrest of cervical dilatation? If in case the curve was initially to the left of the alert line. Okay, to the left of the alert line means normal. Initially, the dilatation was normal. In the first few hours, the dilatation was normal. And then it became static. Then slowly it moved to the right of the alert line. If it is like this, then you call it secondary arrest. If it's low from the very beginning and if it's to the right of the alert line from the very beginning, it's primary. If it is to the left of the alert line in the first few hours and then moves to the right of the alert line in the due course, you call it secondary arrest of cervical dilatation. Okay. So, now see this one. This is an old pathogram where they have included a latent phase. And in the active phase, one X is here and the other X is here. The curve is like this. To the left or to the right? Yes, it is to the left of the curve is to the left of the alert line. So, this is a normal pathogram. Normal pathogram. See this one. Here is where the alert line begins. Here one X is on the alert line. The next X is to the right of the alert line. The next X is touching the action line and the curve is going like this. Okay. This is primary dysfunctional labor. This is primary dysfunctional labor. Okay. See this picture. One X is here. The first alphabet X is here. The next one is here. The next one is here. So, initially it's like this and then it moves to the right. Okay. What is this? This is secondary arrest of cervical dilatation. Secondary arrest of cervical dilatation. Okay. So, we have the next question here. Look at this question. There is a mosquito here. There is a mosquito and it's labeled as Aedes mosquito. Aedes. Okay. Now, it bites a lady and this lady is pregnant. Okay. She's a pregnant lady. Now, this mosquito multiplies in the skin cells, the Langhans cells, and it enters her bloodstream. Through the mother's bloodstream, it reaches the placenta. It reaches the placenta, the chorionic villi. From there, it reaches the fetal circulation and finally, it leads to what? Microcephaly. Microcephaly. So, the answer is very obvious, right? Aedes mosquito, pregnant lady, microcephaly. What is it? Obviously, Zika virus. Okay. So, we'll see more MCQs from Zika virus now. Okay. We'll see more MCQs from Zika virus now. Zika virus. Okay. What type of virus is it? Zika virus is an RNA virus. Zika virus is an RNA virus. It is primarily transmitted by mosquito bite. Okay. Transmitted by mosquito bite. Transmitted by mosquito bite. But please remember, sexual transmission is also possible. Vertical transmission is also possible. Okay. So, other routes of transmission are sexual transmission as well as vertical transmission. Okay. Sexual and vertical transmission are also possible. Okay. And this virus persists in the body fluids for months together. Okay. So, even after many months of mosquito bite, this virus can still be present in the circulation. Okay. What are the symptoms? The symptoms of Zika virus infection. Okay. The symptoms of Zika virus infection are like any other viral infection, any other mosquito mediated viral infection like dengue and other things like say rash, fever, headache, arthralgia, conjunctivitis. So, it's clinically just like dengue, right? Rash, fever, headache, arthralgia, conjunctivitis, and it can also lead to Guillain-Barré syndrome. It can also lead to what? Guillain-Barré syndrome. Okay. Rash, fever, headache, arthralgia, conjunctivitis can also lead to Guillain-Barré syndrome. Okay. Even if the mother is asymptomatic, provided the mother has the virus in her bloodstream, the fetus can be badly infected. Okay. The fetus can be badly infected even if the mother is asymptomatic. Okay. So what is the overall infection rate? What is the overall infection rate? The overall fetal infection rate is 6%. The overall fetal infection rate is 6%. Rate is 6%, out of which anomaly rate if the infection occurs in the first trimester is 15%. So usually, if first trimester is the most vulnerable period for the fetus to develop anomalies, right? So anomaly rate is 15%. Two important numbers to remember. One is 6%. Infection rate is 6%. Anomaly rate in the first trimester is, anomaly rate if infection occurs in the first trimester is 15%. Is that fine? Okay. So this is it. So what are the features of congenital Zika syndrome? The features of congenital Zika syndrome are: number 1, microcephaly. Number 2, lissencephaly. Number 3, ventriculomegaly. Number 4, intracranial calcifications. Okay. Number 5, ocular abnormalities. Number 6, congenital contractures. Okay. So what are the features of congenital Zika syndrome? Microcephaly, lissencephaly, ventriculomegaly, intracranial calcifications, ocular abnormalities, and congenital Zika syndrome. And the diagnosis is by PCR technique. Okay. Do we have any treatment for this condition? No treatment. There is no treatment. There is no vaccine. Okay. No treatment, no vaccine for congenital Zika infection. Okay. Moving on to the next question. Position of the fetus in this image is. See, whenever you get something like this, you have to see 4 things. Okay. First is lie. Whether it's longitudinal lie or transverse lie. Okay. See whether it's longitudinal or transverse lie. Now here it is longitudinal lie. Correct? In case of longitudinal lie, it will either be, vertex presentation, cephalic presentation or breech presentation. Okay. Cephalic or breech presentation. Correct? Yes. The next thing you have to see is attitude. Okay. In cephalic presentation, the most common is cephalic presentation, right? In cephalic presentation, you have flexion attitude, extension attitude. Okay. Flexion attitude and extension attitude. Now see how the fetus is, whether the head is flexed or the head is extended. Okay. Accordingly, you will choose the denominator. If the head is flexed, the denominator will be occiput. If the head is extended, the denominator will be mentum. Okay. So I have told you 2 points. One is lie, the other one is attitude. Now look at the picture. Tell me what the lie is. Longitudinal or transverse lie? Longitudinal lie. Cephalic or breech? Cephalic. So when it's longitudinal lie in cephalic presentation, there will be only 2 denominators. One is occiput. The other one is mentum. Now see the attitude of the head. Attitude is flexion or extension. The baby's head is nicely flexed. So now ultimately you have come to a conclusion on which denominator to choose here. The denominator that you will choose is occiput. You will choose the word occiput. Occiput. Okay. The next job is to identify the position. Okay. So please follow the order that I am telling you when in case of picture based questions. Okay. So in case of picture based questions, please follow the order that I am telling you. First you see the lie, then you see the attitude, then you see the denominator, finally you see the position. Okay. Now to see the position, pictures can either be like this or the pictures can be like this. Okay. The picture can be a longitudinal view or a transverse or a cross-sectional view. Okay. See, if it's a longitudinal view, your job is very easy. Okay. Depending on whether the occiput is on the right side or the left side, you can just choose left occipito, right occipito, anterior and so on. Okay. Now, in case the picture is like this, cross-sectional view. Okay. Here is where the problem comes. Okay. Now, in case you see the cross-sectional view, please see what is shown in the pelvis. Okay. Now, whenever you see this kind of a picture, always assume that this is right side of the mother and this is the left thigh of the mother. Okay. So, this is the right thigh of the mother. This is the left thigh of the mother. Okay. Now, see the fontanelles. Okay. So, what you have here is a diamond shaped fontanelle. That means this is the posterior fontanelle and this is the anterior fontanelle. This is the posterior fontanelle. This is the anterior fontanelle. Okay. Posterior and anterior fontanelle. Now, remember. So, posterior fontanelle is diamond shaped. Anterior fontanelle is triangular. Okay. Now, why should you know this? Because occiput is close to the posterior fontanelle or anterior fontanelle. Occiput is close to the posterior fontanelle. Occiput is close to the posterior fontanelle. I am telling you all this basically to identify where the occiput is. Occiput. Once you put the word occiput, next you have to decide on whether to put left occiput or right occiput. No? Yes? Here the lie is longitudinal, attitude is flexion. So, you will use the word occiput. But right occiput or left occiput depending on where the fontanelle, posterior fontanelle is. Okay? Anterior fontanelle is diamond shaped and posterior fontanelle is triangular. Okay? Just note this down. Anterior fontanelle is diamond shaped, diamond or rhomboid. Posterior fontanelle is triangular. Okay. So, where is the posterior fontanelle? Here in this picture, the posterior fontanelle is to the left. This is the posterior fontanelle and it is to the left of the patient. Okay. This is the posterior fontanelle and it is to the left of the patient. So, occiput, left occiput or right occiput here? In this picture, it is left occiput and this is anterior. This is anterior quadrant. Okay. This is anterior quadrant. This is posterior quadrant. Okay. So, it's left occipito anterior. Okay. Now, look at this picture. This might look confusing to you. Now, I will tell you how I am deciding on this one. Okay. Just look at this one. Here it is longitudinal lie, flexion attitude. So, occiput is the denominator. Occiput is the denominator. Okay. Now, right, left, anterior, posterior. That's what I have to decide. Okay. See, here is the posterior fontanelle. Here is the posterior fontanelle. So, this is right of the patient. This is left of the patient. So, the posterior fontanelle is to the left. That means occiput is to the left. So, now I know it is left occiput. Okay. Now, how do I decide on whether it's anterior or transverse or posterior or right anterior? See, in a normal pelvis, if say you see a circle like this is direct anterior, this is, left anterior, this is left transverse, this is left posterior, This is direct posterior. This is right posterior. This is right transverse. This is right anterior. Here is the right thigh and here is the left thigh. Okay. So I have just zoomed the image of what we saw previously. So here, now in the previous picture that we saw, the fontanelle was something like this. It was something like this. It was here. The anterior fontanelle was here. The posterior fontanelle was here. So it is LT. LT means what? Left transverse. Left transverse. Okay. What is the denominator? Occiput. Occiput is in the left transverse quadrant. That's how it goes. Okay. What is it here? Here it is right. This is right. This is left. Okay. And you can nicely see the occiput in the anterior quadrant. This is right occipito-anterior. This is right occipito-anterior. Okay. Last question here is on the grip. Identify the grip. How many grips do we have? We have 4 grips. Okay. We have 4 grips. Obstetric grips, and they are called as Leopold maneuvers. They are called as Leopold maneuvers. Okay. So Leopold 1, 2, 3 and 4. Leopold 1 is called as fundal grip. Fundal grip. Leopold 2 is umbilical or lateral grip. Umbilical or lateral grip. Okay. Leopold 3 is first pelvic grip. First pelvic grip, which is otherwise called as, first pelvic grip is otherwise called as Pollick's grip. Pollick's grip. Okay. Leopold 4 is second pelvic grip. Okay. Second pelvic grip. So we have 4 grips: fundal grip, umbilical grip, Pollick's grip or first pelvic grip, and second pelvic grip. Out of these, remember, Leopold 1, 2 and 3 are performed with the examiner or the obstetrician facing the head end of the patient. Okay. Facing the head end of the patient. Okay. Leopold 4 is the only maneuver. It's the only maneuver which is done with the obstetrician facing the foot end of the patient. Okay. Leopold 1, 2 and 3 are done with the patient facing the head end of the patient. Leopold 4 is the only maneuver which is done with the patient facing the foot end. Okay. So here, this is Leopold's 1. This is Leopold's 1, which is fundal grip. Fundal grip. This is the fundus of the uterus, and what you feel here is a soft, broad, not independently ballotable mass which is suggestive of breech. Not always breech, but most of the time breech. Okay. In cephalic presentation. So lateral grip. This is lateral grip. Leopold's 2 or lateral grip. Okay. So here, what does the examiner feel? On one side, the examiner or the obstetrician feels the back of the baby, and on the other side, the limb buds. Okay. Back on one side and limb buds on the other side in lateral grip. Okay. Third pelvic grip and the first pelvic grip and the second pelvic grip are Leopold's third and fourth grips. Okay. This is Leopold's third grip. This is Leopold's third grip. So the baby's head is holded in a cupping manner like how it is shown in the picture. This is Leopold's 3. And this is basically to see whether the head is mobile. Okay. And to confirm whether it is cephalic presentation. First of all, to confirm whether it is cephalic presentation and to see whether the head is ballotable. Okay. Mobile. Fourth pelvic grip. Fourth Leopold's grip is second pelvic grip. Okay. This second pelvic grip is to confirm the findings of the first pelvic grip. First of all, to see whether it's cephalic presentation, to confirm that it is head, and then finally to see whether the head is engaged or mobile. To see whether the head is engaged or mobile. Second point is to see the attitude. attitude. Okay. So in what way does it help? In attitude. Okay. See, listen. Now say this is the brim of the pelvis and this is the ischial spine. Ischial spine. When will you call it an engaged head? If the maximum transverse diameter of the fetal skull has crossed the brim of the pelvis, you call it engaged. And say this is the maximum transverse diameter. This is engaged head. Okay. So when the head is engaged, please remember, when you insinuate your fingers on either sides, okay, when you insinuate your fingers on either sides to touch the head, to hold the head, your hands will diverge because maximum transverse diameter has crossed the brim. See, the shape of the head is like this only, no? The hands will go like that, okay? The hands will diverge, okay? So if the hands diverge, then it is suggestive of engaged head. It is suggestive of what? Engaged head, okay? On the other hand, if it is mobile head, okay? If it is mobile head, say this is the brim of the pelvis, this is the ischial spine, okay? And say this is the fetal head. The fetal head is completely above, okay? Mobile head. In this case, what will happen? See, the head is coming like this. The head is coming like this. The maximum transverse diameter is here and below that the head is actually converging, okay? Below that what's happening? The head is actually converging, okay? So if the hands are converging, then it is mobile head, okay? In the second pelvic grip, if the hands are diverging, it's engaged head. If the hands are converging, it's mobile head, okay? That's how you have to remember. Next is, it also helps in identifying the attitude. Attitude. How does it help in identifying the attitude? Depending on the position of the sinciput and the occiput. This is sinciput, this is occiput, okay? Please remember this point, okay? Please remember this point. If the sinciput is at a lower level, than occiput, it means the attitude is extension. If the sinciput is at a lower level than the occiput, it means deflexed head, okay? It means the attitude is deflection. It is not complete flexion. If the sinciput is lower than the occiput, it is deflection, okay? Ulta is flexion, complete flexion. If the sinciput is higher in position than the occiput, then it means it is complete flexion. It is flexion attitude. Now, what is the use of the second pelvic grip? What is the importance of second pelvic grip? Second pelvic grip helps in identifying not only the engagement of the head but also the attitude of the head. It helps to see whether the head is engaged or mobile. It also helps to see whether the attitude is flexion or deflection. Okay, so this is about the picture here. Let's see the question. So it's very easy. It's lateral grip, no? The answer is what? Lateral grip. Okay, so this is lateral grip. So here we finish the discussion on the recent INI-CET question paper.